Good evening, aspirants, and our faculty for today is Dr. Hirak Mondal, and he would be conducting today's class of organ donation and transplant. He's a consultant in Department of Critical Care Medicine, in charge gastro and liver transplant ICU at NH Rabindranath Tagore International Institute of Cardiac Sciences, Kolkata. His area of interest are in liver transplant. Over to you, sir.
Very good evening and warm welcome to all the aspirants. What we're talking about, donors. So first we have to classify what are the different types of donors. So based on that, we have brain dead disease donor. This is the most common type of donors that we all know. In 80% of cases, we receive organs from these brain dead donors. The definition of brain dead, it varies from country to country. So like in the most of the countries where we follow the UK protocol, or Asian countries, brain dead is equivalent to brainstem dead. I will discuss it later regarding what is brain dead, what is brainstem dead, and how we'll manage a patient of brain dead in our ICU who is a potential donor. So next is disease after cardiac death. This is another type of death where patient doesn't fulfill the criteria of brain death, but patient relatives, they are willing to donate organs after the death. Then what we do, we remove the circulatory respiratory support in a controlled environment, like in critical care unit or in operating room. Then one doctor who is not attached to that organ transplant team per se, who declares the patient dead, and immediately transplant organ procreation for transplant has been started in that case. So there are potential two types of donors: donation after brain death and donation after cardiac death. Now another type of donor is living donors, like in kidney transplant. We know we can donate a kidney, even we can donate liver, small bowel, pancreas, and lung. And the numbers of living donors are increasing day by day because there is always a shortage of after death donations. So these living transplants, they may be either genetically related to the recipient or may not be genetically related. But one criteria is that they must be emotionally related. Regarding this living donor, one burning issue is whether we are doing anything like it's like an industry, in some part of this world, they are doing this living donor transplant is like an industry. So it's beyond our discussion. We will not discuss into that, but there are some debate about the scope of this living donor transplant who are unrelated. Now, going into details, what is brain death? You will be asked question in your EDIC exam regarding brain death and brainstem death, and how to manage a patient, brain death patient in your ICUs. So it is a complete and irreversible cessation of brain activity, and evidence of irreversibility is required. Like there is no motor function, the GCS is E1, VT, and M1. There is no response, and then what we do apnea test and some ancillary tests to declare the patient brain dead. So there must be an factor that could be able to do this severe kind of damage that must be present, and there should be no response. And third one is apnea test should be positive. So regarding this, you may ask question about apnea test and different brainstem reflexes like corneal reflexes, and what is the nerve root value, you may be asked. So being intensivist, what is your role to treat a patient who is a potential organ donor? So you have to maintain the hemodynamic stability, you have to diagnose the neurological death, and you have to prepare the family. You have to take you have to counsel the family sometimes repeated times, because they are not most of the family members, they are not willing to donate organs so easily, because they are receiving some kind of news And on the other hand, you are asking them to give some consent for organ transplant. There is that's not so easy. Even you can take help of some other facilities and some emotional psychological support you may ask family member, they may ask. So there are some implementing policy and protocols for organ donation, and communication with other teams like transplant coordinator, organ procurement team, family members, and other multidisciplinary teams. It's required in part of a intensivist. So there are some excellent guidelines regarding management of potential organ donors. I am not going details into all of those. Here is a reference of a guideline. It was published in Indian Journal of Critical Care Medicine 2007. It's an excellent guideline. If you get time, it's as advisable that you go through it. So next is pathophysiology. What is the pathophysiology of brainstem death? So what happens in brainstem death? There is a loss of vasomotor control initially, so leading to an hyperdynamic state. It may cause to cardiac arrhythmias, loss of respiratory function, and other events like loss of temperature regulation and hormonal imbalance. I will discuss in one by one. So severe trauma and stroke, they cause damage to the tissues, increasing ICP, decreasing cerebral perfusion pressure. Ultimately, there occurs a vicious cycle where ICP goes on and on, CPP goes down, and more damage to the brainstem, and ultimately herniation occurs. This herniation occurs to rostral to caudal path, that is from midbrain, pons, and lastly from medulla. So what is the initial responses? Initial response is hypertension and bradycardia. This phase is called Cushing reflex, that you all know. As the brainstem becomes more ischemic, the vagal cardiomotor nucleus becomes ischemic, causing unopposed sympathetic stimulation and leading to a, I was talking about unopposed sympathetic stimulation, which cause tachycardia, hypertension, and high blood level of catecholamines. So this is called autonomic storm or catecholamine surge. After this phase, there is a profound reduction of sympathetic outflow, and there is loss of autonomic tone, causing vasodilatation and hypotension. So, and there occurs damage to hypothalamus and pituitary, resulting in temperature and endocrine dysfunction. And there is interruption of hypothalamo-pituitary adrenal axis. So, at this period, circulation must be supported, and artificial respiration must be started. Okay. So, in short, what I have said, there is Cushing reflex. There is cytokine surge, may cause myocardial depression. There is some spinal cord ischemia causing hypotension. There is myocardial ischemia, and catecholamine storm may cause neurogenic pulmonary edema. And release of pro-inflammatory mediators may cause lung injury. And there is some kind of lung dysfunction like atelectasis aspiration. There is elevated renal tubular biomarkers. There is pituitary ischemia causing multiple endocrine problems. And hematological, there is plasminogen activator can cause DIC. This area that I have said in last 2 to 3 minutes is very important for your EDIC exam, because multiple questions might be asked in this topic. So I will discuss one by one. First, what are the points? One is hypothermia, hypotension, diabetes insipidus, DIC, cardiac arrhythmia, pulmonary edema. These are the points that you have to keep in your mind regarding management of a patient as a potential organ donor. And there is a rule of 100. Your systolic blood pressure should be kept more than 100. MAP usually kept more than 70. Urine output that we keep around 0.5 to 3 ml per kg per hour. Target should be more than 100. PO2 should be kept more than 100. Hemoglobin concentration should be more than 10 gram. And sugar should be more than 100. This is called rule of 100. This is a very handy thing because this rule of 100 often asked in EDIC exam, and it's very easy to remember. Now, one by one management that I have already discussed. First, systemic hypotension is very common. So, fluid displacement is the first thing of therapy. We'll start with isotonic crystalloids, and here occurs a cause of 𝒉𝒂𝒂𝒓𝒔. So we have to start vasoprestic drug. We have to start vasoprestic drugs, vasopressors like vasopressin, noradrenaline. Here, noradrenaline is a drug of choice because the best vasoactive drug is not known. There is no drug is the drug of choice. No drug is called the drug of choice, but noradrenaline is the preferred drug for management of this hypertension. And combination of dopamine and noradrenaline is usually given when myocardial depression is there and you want to start inotropes and chronotropic agents. Is there any question regarding that? Are you clear? Are we clear? Because I want to do discussion in a two-way fashion. So do you have any questions till now? Regarding that autonomic storm that I have already mentioned, there is a release, huge release of catecholamines, epinephrine and non-epinephrine, which causes tachycardia, elevated cardiac output, vasoconstriction, and hypertension. This is an extremely dangerous condition for the potential organs. So we have to control that tachycardia and hypertension. For that, we have to start short-acting beta blockers or sodium nitroprusside. One question is often asked, what is the drug of choice? So drug of choice is sodium nitroprusside and short-acting beta blockers like S-monol. It's often asked in our EDIC exam. So don't forget it. And we have to give anti-arrhythmic drugs to control arrhythmia related to cytokine storm. Bradycardia usually resistance to atropine. So, do you have any idea why this bradycardia is resistant to atropine? Anyone?
Because the sympathetic innervation to heart is lost. So
exactly, atropine is a vagolytic drug, and already it's lost. Vagal stimulation is already lost, so atropine will not work. Here, the drug of choice is isoprenaline. So always remember it. Isoprenaline is the drug of choice.